Dr. Leila Mohan to present her talk on genetics in congenital cataract. Now, genetic study is becoming more and more important, and we are doing it more and more frequently. Dr. Leila, please give your talk.
Thank you. Thank you, Dr. Elizabeth. So, genetics, which we don't regularly do in every congenital cataract. So, as already pointed out, congenital cataract is the main cause of treatable blindness in children, and intrauterine infections account for about 20%, which is more common in developing countries like in India, and about 50% of bilateral congenital cataracts are inherited. And inherited cataracts may present at birth, may be congenital, or during infancy or later, much later during the first or second decade also. Most of the non-syndromic inherited cataracts are autosomal dominant, but recessive or X-linked can also occur. And syndromic associations with metabolic disorders like galactosemia, chromosomal abnormalities like the most common being Downs, or multi-system disorders like Lowy syndrome are not uncommon. And gene mapping in congenital cataract can throw light into the molecular pathology in development of cataract, both in congenital as well as in age-related cataracts. So, some of the genes causing cataract, the lens transparency is maintained by lens crystallins, membrane proteins, and filament proteins. Recently, the role of chaperones, growth factors, collagen, and extracellular matrix components have been shown. And in congenital cataract, severe gene mutations lead to damage to lens proteins. In adult cataract also, a destabilization of proteins make it more susceptible to environmental insults like UV light, hyperglycemia, and oxidative stress, making some patients more prone to develop cataract earlier than others. So there are about more than 100 loci and 56 causative genes identified in causing cataract. So genes for the eye and lens have been identified. PAC6 was identified as a master control gene. Dr. Soumya has pointed out the developmental sequences from 22 days onwards to 23 days from lens placode to pit vesicle and separation. It has been shown that PAC6 is the control gene for eye development by genetic manipulations in Drosophila and mice and in human studies as well. So PAC6 mutations have been associated with aniridia, anophthalmia, microphthalmia, and cataract. PITS3 on chromosome 10q has been associated with dominant posterior polar cataract and microphthalmia, and FOXE3 required for lens separation and proliferation has been implicated in anterior segment dysgenesis as well, and a recessive cataract. So genetic mutations affecting specific parts are there. Crystallins, which account for 90% of the lens proteins, are responsible for about 33% of the mutations producing, gene mutations producing cataract. And the rest, mainly the transcription factors, connexins and membrane transporters and chaperones. So phenotypically, inherited non-syndromic cataracts are variable in presentation. Even inside in the family, they may present differently. Fetal nuclear cataracts suggest early developmental genetic expression, mostly affecting the crystallins. The gene mutations are CRY, and BB1, and lot more. And lamellar perinuclear opacities are common, which also affect the crystallins mutation affecting the crystalline gene. And bilateral anterior polar symmetric non-progressive cataracts, not visually significant. We don't need to operate them. As you see here, pinpoint anterior polar cataract. But sometimes they may be associated with microphthalmia, and a gene may be involved in anterior segment dysgenesis as well, and 17q13 may be involved. Bilateral posterior polar cataract may progress later in life. We see often after 30s that they develop glare, and visually they become significant much later, though they have been there all along. And being at the nodal point can affect vision much later. And cerulean cataracts has been seen, very commonly seen in Downs. It is even seen even otherwise, often phenotypically variable in severity in the same family, and they do not affect vision. Congenital cataract was the first autosomal disease to be genetically mapped in humans, and cerulean cataract was the first monogenic inheritance recognized in 9 generations of a British family in 1909 with the Duffy blood group, and later mapped to chromosome 1. And later, the next generation sequencing of families using gene panels, the whole exome sequencing, and even whole genome sequencing accelerated cataract gene mapping in congenital and adult cataracts. Other protein coding genes are associated, and GALC1 homogeneous mutations in chromosome 17q in recessive galactokinase deficiency, leading to galactosemia and galactitol accumulation in lens, producing osmotic cataract giving oil droplet appearance, as we have seen, can be reversed with a lactose-free diet after early diagnosis or even enzyme replacement therapy. So lies the significance of diagnosis in these cases. And GALC1 carriers have an increased risk of age-related cataract as well, even though they didn't manifest as a congenital cataract. So FTL gene on chromosome 19q in hyperferritinemia is an autosomal dominant condition producing crystallization of ferritin in lens, producing this breadcrumb appearance. So other common genes are glucosamanyl transferase gene, GCN22, CHAMP-B gene, mitochondrial DNA, which is associated as a maternally inherited lamellar cataract, which is commonly seen in India. We see maternally inherited lamellar cataracts, very common. We do see in our place, family, their children and grandchildren developing lamellar cataracts. HSF4 associated lamellar cataract, and some of these genes are associated with recessively inherited cataracts in Arab families and in Chinese families. So regionally there can be different genetic transmissions. And WFS1 in Wolfram syndrome with the diabetes mellitus and insipidus with optic atrophy and also cataract. So some X-linked syndromic cataracts are also there. Lowy syndrome with the mutations at OCRL gene on chromosome XQ25 with the proximal tubular dysfunction and aminoaciduria and intellectual disability. Female carriers may show radial cortical opacity, so it is good to see their parents as well, mothers as well. Norris disease is an X-linked recessive mutation with retrolental vascularized mass with iris atrophy leading to the iris later in life. Nance-Horan syndrome with X-linked dominant mutation due to mutation of NHS gene with dental molars, Mulberry molars. As Dr. Soumya has already pointed out, it is good to see the systemic manifestations, see them as a whole, and a pediatric examination is very important. And chromosomal abnormalities, the most common being Down syndrome, often they come after karyotyping. They have already been diagnosed, and trisomy 13, Patavos and 18, they have all have systemic associations which produce lot of other comorbidities which affect their life quite early. So metabolic diseases, which some of the inborn errors of metabolism phenotypically, if you diagnose genetically, if they diagnose early, can be prevented. Congenital lamellar cataract, microphthalmos, short stature, PX11B, due to peroxisome biogenesis disorder, can be treated with vitamin K, DHA and restricting phytanic acid. Infantile central lamellar cataract with spastic diplegia and cirrhosis by cholesterol biosynthesis and cholesterol reduction. Childhood PSEC, posterior subcapsular microcephaly dystonia. Lathosterolysis, cholesterol reducing drug can be used in these cases. Infantile nuclear cataract, as seen already, galactokinase deficiency, and congenital cataract with seizures with stromatin deficiency with a ketogenic diet, and juvenile onset lamellar cataract and peripheral neuropathy with a cerebrotendinous xanthomatosis can also be treated by chenodeoxycholic acid. So investigating molecular etiology of congenital cataract after family history, pedigree tracing, torch titer, amino acid reducing substance analysis, and metabolic diseases like galactokinase. If systemic features of delayed motor and cognitive development are there with the dysmorphic facies, karyotyping should be done. And Saga sequencing may be done if gene is known, like Lowy syndrome is diagnosed by the pediatrician, you can go for a specific OCRL gene mapping. If genetic etiology is suspected with no distinguishable features, then whole genome sequencing can yield better results. But a targeted gene panel of cataract related genes using next generation sequencing yields better results. And next generation sequencing is the way to go now, where millions of DNA fragments are simultaneously sequenced and gene expression is better. And it is cost effective too now. Genetic testing can integrate the results into clinical practice in family planning and in prognosticating and reducing comorbidities. So some of the gene-based therapeutics have been in trial now, even to the extent of some eye drops. Many of these genes are implicated in early onset adult cataracts as well, and gene therapy with gene editing tried in animals models. Thank you.
Thank you, madam, for that exhaustive talk. Little difficult to remember all those numbers.